It's so nice to be here. Thank you very much for inviting me to give this talk. My name is Lisanne Craven. I'm one of the speech pathologists at the Louisville Center for Voice Care. We have been open since 2016, and last year my group came on as staff. I have been around the community for many years doing speech pathology with a specialist in voice. So I have been working for most of the ENTs in Louisville and at several of the hospitals doing therapy, but then in 2018 I came on full-time at the Louisville Center for Voice Care, which is U of L's. So there are 3 speech pathologists there. We do voice therapy, and because of our love of voice, Parkinson's has also become a big draw for us. So we enjoy doing Parkinson's treatment, and we're trained in the LSVT and the Speak Out, both programs for voice. And then we have a laryngologist there who's with U of L too, Dr. Chandran. So ENTs that specialize in voice are laryngologists, and she's the director of our center. So why am I here? How many, can I see a showing of hands of how many notice changes in their voice? Big percentage. How about swallowing? Any changes in swallowing? Okay, so we've got that too. So these, I'm not telling most of you anything you don't already know, but some things that we notice voice, the most common is a decrease in intensity. That soft voice becomes the most prevalent feature that we see and complaint we hear. Many times a monotone voice. That can make it very hard to convey feelings, and as you guys know, voice, we're connected to our voice. It's a part of who we are, and when things like that, the intensity and that intonation change, it can also make it harder to communicate, because those listening to you may not be able to convey, you may not be able to convey the meaning of what you're saying, even though the words may be understood. When the voice is more monotone, it's a little bit more difficult. Sometimes a hoarser strained voice is common. And again, that breathy voice, and I'm going to talk about why this happens. Sometimes a tremor, slurring of words. The short rushes of speech it can be common. Usually it's either monotone or short rushes. One of those prevails a little bit more. And the lack of facial expression can be make it much more difficult to communicate too. And then with swallowing, certainly the difficulty with chewing and even controlling saliva sometimes may be difficult. As shown by the hands here, it's a very prevalent feature of Parkinson's. Some studies show up to 90%, 75 to 90% is usually what we see now in people with Parkinson's who have difficulty with speech or voice. We tend to refer to speech as the intelligibility, how clear it is, the articulation of and the voice, what's happening with the quality of the sound signal itself becomes the voice. So the softness, we look at these a little bit differently. Swallowing disorders, much more harder to give us a percentage on how many have those. It's usually something later occurring, but there's been as many as they say 30 people will say that they recognize, about 30% recognize swallowing, when in testing they'll show as many as over 80% actually have observable signs of a swallowing difficulty. And as you guys know, I'm not telling you anything you don't. Both movement and non-movement disorders can be part of Parkinson's. Both of these interfere with our ability to communicate, and that's what I want to talk about today, how the voice works, because I feel like the more you know about the process, the more you'll be able to appreciate and understand it. So I want to talk a little bit about just some fun facts about the vocal folds. Most of us few of you have seen your vocal folds, I'm sure, but not everybody. So they're very small, about the size of your thumbnail bed. And the mass, the weight of the vocal folds, about a gram, which is about the weight of a paper clip. They're tiny structures. It's amazing, I call this prime real estate here because that's what protects our airway. That's their primary job, is airway protection. We would think it's voice and communication, but actually it's the ability to close to protect our airway. And also to establish an efficient, forceful cough. And when that doesn't happen, we can create lots of problems. So we had the coins over here are showing the female size are usually between the two smaller size, which is the size of a dime, to a penny, and then or to a nickel, and then a nickel to a quarter the size of male. But as you know, from the primary feature being airway protection, but the most lovely thing about this structure is that we can talk and sing and communicate with people we need to communicate with. So have a little, you know, when you think about the size of the vocal cords and comparing it to the size of a piano, we're pretty lucky with the structure and what it can do. They vibrate very fast. And that's what we look. I image vocal cords a lot. It's part of our voice evaluation is to do stroboscopy, and it's a specialized image that shows how that cycle happens. And I'm going to show you some pictures of that. The female speaking rate is very fast, 170 to 220 cycles per second. So,
amen, sisters.
And with singing, it can go even up to 1,400 cycles per second. Hard to even conceptualize, and that's why when we do imaging of vocal cords, we have to slow it down. So let's talk a little bit about voice production, and this can hopefully, you know, I think when we don't see our vocal cords, it's hard to understand why things can go wrong. But in subsystems of voice, it's a very coordinated system with muscles needing to work in a timely manner and be very efficient. The power source for voice is air. And that comes from the lungs. That respiration is what drives the voice. How many of you have done voice therapy? So good, and probably a lot of that has been, not as many as I've had hands up for voice problems. So, but you've probably done work on loudness.
Hey, me, my,
You got it. So we call this the filter source theory, where we're driving the voice with air. What starts that vibratory cycle is at the vocal fold level, but really here it's just noise. It's just a buzz. How we shape that sound and what we do with our voice is what happens above the vocal cords. And this part, we have control of that breath and also a lot of control of where we place that voice, which is not something most of us ever think about. We're thinking about what we're saying, not how we're saying it. But just as I can place my voice down here in the back of my throat. It's harder to listen to, right? It's in the back of my throat. But I can also pick it up here and have a much more resonant voice. And that is something we don't really think about, but we have a lot of control. And just like muscles, the longer I'm here, the longer I want to go here. We all have variability in that voice, and that's what we hope to maintain, that different voice. I say often I have my speaking voice. I also have my grandkids' voice. They can be different voices, but a lot of that is how you place your voice in the vocal tract. We strive for an ideal voice to be much more forward, but all of us, we get tired in our voices down here at the end of the day. That's okay. Just knowing that you've got things that you can do to make it different. And again, another picture of just so that you can see the placement in the vocal cords. The top picture shows at the very bottom the vocal folds and what happens as the air streams up. Now that tongue is also going to be moving, and that can open that resonating chamber or reduce it depending on where that base of tongue is. So I know this is a side view of the vocal folds in motion at the top. I like that picture because we don't ever think about that, but that's air streaming through that's going to create your voice. And I didn't say this before, but if anybody has questions, feel free to ask as we go. So, I want to show you a normal vocal folds in motion. Tongue way out and move this up a bit. And then we'll talk about what happens they lengthen and straighten. The lower the pitch, they get loose and more relaxed. So, as you know, with Parkinson's, it's changes in muscle. Get out of that. Get that tongue away. And this can certainly alter what happens with the voice. And as you can see, that was a very coordinated motion. When we raise the pitch, the vocal folds actually elongate. So just like muscles in that, big muscles we can see, these tiny muscles also change based on any muscle weakness or variability because of the Parkinson's. So the most common visual thing that we see with a Parkinson's disease is a bowing of the vocal cords, a thinning of that tissue. This also happens, and it's said very often, unfortunately, it's the common thing that we see just in normal vocal folds that tend to age a little bit. Like all skeletal muscle, our muscles can weaken over time, and a bowing of the vocal cords can cause a gap. That gap can also give you sort of a breathy voice. It's one of the reasons in doing LSVT, if you've tried those kind of get loud, and it's hard. When our cords can't come together, we have to work so much harder to get that air projected to get closure. And if the cords are weak, that may not happen. So we like to get a look before we do therapy just to see that this is not something that needs addressing on its own. And many times there's some treatment for that now. I'm going to show you this in visual. You'll see that the cords do not fully come together, and you hear that breathiness. And you see that the pink tissue on top, those are false vocal cords that are trying so hard to help.
Can you do this? I want you to breathe through your nose and say E, like just a sniff, like
So when that pink tissue that's adapted and trying to help out, we call that the ventricular fold or the false vocal cord. When those come into play, it can actually be more like the brakes are on. It's hard to get past that sound. So we're fighting two opposing problems: an open vocal fold that's not closing, an area that shouldn't be closing that is. So that's a little bit of what happens here. And the other reason that we like to look is that many times in our voice treatment, we have to do modifications. So this is someone you may recognize. He said it was okay.
Yeah, we heard that.
I want you to try this. Look at me. I'm going to have you sniff and then out loud. So on. So this is, try this.
This is not a I'm sorry, I didn't mean to not so much a problem with volume as quality of sound. Complaints were roughness in the voice, and as you see, I'm sorry, hitting the wrong thing here. E, you'll see a tiny little bump on that. The right vocal cord is closer to me. The left vocal cord is on that side. There's a tiny little bump. And so that little bump causes a little bit of roughness in that voice. So, anybody recognize that sound? Thanks for allowing us to show, but we like to look because when roughness is in there, it's hard, I think, sometimes without getting a look at the vocal cords. My tendency is always to just try to, kind of overdrive it. We're gonna do what we need to do with LSVT, which is get loud, get loud, get loud. I had to modify that program a lot because we want safety in there. The louder you hit, the more we're gonna irritate that tendency of that tissue to swell. So I'm going to talk about what we do with in speech therapy. Yes.
I'm sorry, because you were saying something about the bump, and I missed. So what was that exactly?
It's just a little tiny nodule. Those are little benign bumps and lumps that occur on vocal cords often.
All right.
Many people who are talkers get those a lot. We see them routinely, and it can be. I don't like to use the term overuse. It's sort of one of those, we don't know why some people get them and others don't. It may be a condition of vulnerability of that tissue, that a single event occurrence, or it can be just over time.
Mine's going to be covered then.
And I always tell people, I have singers that are just always, can we look? I always say it's how it sounds, not so much how it looks, because many people think about singers, do you think Bob Dylan's chords are nice and smooth and straight? Absolutely not. He can make a living from it. So it really doesn't, it doesn't matter so much how they look, unless, certainly there are times when we see things that are concerning and they're look suspicious. That's the time to do a biopsy and surgery, but that's the most rare of what we see.
Okay.
So who has heard of the therapies for speech for Parkinson's? LSVT or Speak Out? You? Okay. Which ones? Speak Out. Yeah. Speak Out's the newer one. Yeah. You did you do LSVT? Okay, you did. Okay. The LSVT program was the first Parkinson's voice program. It's of all therapies that we do, it has the most evidence-based research behind it. It's very involved. The actual program is 4 times a week for 4 weeks. I have found it hard to find people who can actually do 4-hour commitments a week. We've been helped through COVID by the ability now to be able to use telehealth. Before COVID, speech pathology could not use telehealth as an option, so that did help for many people to be able to stay at home and do this, and it was a great option for Parkinson's for telehealth. It was easy to implement that. There are many apps on the phone that allow us to track our intensity level. There are things like that we've been able to use. It has to be a trained LSVT provider, and I know probably some of you have been in the LSVT BIG too, the therapy. So the other one that's started, it's called From the Parkinson's Voice Project, is the Speak Out program. That's also an evidence-based practice. It's designed on and there's some great research behind this. We have a lot of our patients who have really enjoyed this. We do a lot more conversational work and even some cognitive work here. But it's one of the findings is that dopamine certainly is the key ingredient in those neural pathway transmissions that happen in in the automatic nervous system, and unfortunately 80% of that can be diminished by the time that movement disorders or changes are actually identified. So this was based on the principle of using the non-automatic, or what we call the pyramidal nervous system, to take over the extrapyramidal or the automatic. If you think about this, it's sort of like if I asked you to count to 10, your body would go right away, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's our autonomic nervous system going into play. But if I said, okay, start from 100 and count back by sevens, that would be a much more intentional, and who, if you've done the speak out therapy, you know the word intent. Speak with intent. And that's exactly what we're doing, is trying to change our motor pathway to use that intentional system to help with voice production. The other thing, and I don't think I talked about this much, but in Parkinson's, that perceptual ability, it can be diminished, and almost everybody in this speak with intent tells me, I feel like I'm shouting, I feel like I'm shouting. And it usually doesn't sound like that, but we know that can be a difference here. And because when we went back to that, filter source theory of voice, sometimes even the diaphragm, that respiratory system for breath, can be diminished. And when that's not working, it is more effort. One of the things I feel like in this intent, we have to just really remember to talk louder than you think you should. And it takes time, and it's practice, but muscle memory can help us out. So in this session, in Speak Out, we usually do these once a week at our facility. It's typically designed for 8 to 12 sessions, and then 6-month checkups, which I think has been helpful for a lot of people to have those kind of check-ins as we go. We also can work on additional problems that happen, like roughness in voice, or for some people, articulation, things like that can make a difference. And I'm not sure why that one came up there out of context, but I want to talk about some other things. I showed those pictures of the bowed vocal cords where they're wide open instead of closing. There's some amazing treatment options now for that. If someone is doing Parkinson's therapy and they're straining so hard that they can't get a true voice, and we see that bowing. We've had great success with the laryngologist doing an injection of the vocal cords, so that it fills it up. It's sort of like a facelift for the voice. It actually plumps those vocal cords up. They put an injection in. It's usually something it's a calcium hydroxyapatite. It's like what they use for deep wrinkles, very skin friendly. You know how fast those vocal cords vibrate, and it's been a great outcome for that. Typically we find doing a little bit of therapy first, and then if they're not doing well, we work as a team at our facility, and we'll let the laryngologist know, I think we've done what we could. This becomes an awesome option. We had somebody come in last week that was so happy with his outcome after surgery. So it's done one of two ways, either in the office where they kind of feel and inject. We'll put a scope in while that's going on, and then the physician, the laryngologist, will inject a filler right in, and usually outcomes great. The other one, I'm going to go back here, is in the office, and you can see here on the side that cord's thin, and they plump it up It looks fatter than it should there, but we know it's gonna dissipate over time. And it gives us great outcomes for good voice.
And how long does that last?
Great question. The one that they started with was only a 3-month. But now what most people do is put in one that's more, the first one was a gel texture, now it's a little pastier, thicker, and it lasts about a year.
Oh, wow.
Now, you know, we've had the other thing, like every muscle, once you're moving it, and when you can make contact, it moves easier, it moves more steadily. And we've had some people that have lasted much longer.
Wow.
And so you know, once you're injected, we have you come back in the next week or two just to see, but I like people to know that's out there because it is an option that wasn't always available. And certainly, voice is so important to me, and I know to all of you, it is something that we take for granted so much of the time, and until something goes wrong, we don't realize how crucial it is for day-to-day communication and conversation and just what happens in our life. So
Yeah, that's amazing. And so now after they get that injection, would they still do the speech therapy and to still strengthen it up while it's easier to do?
Oh, yeah.
Okay.
If there are other, you know, especially if there are other issues, if it's more than just volume, if there's some difficulty driving the voice efficiently, we want to make sure that you're not right here. So if I say get loud, the cords have to stay together just a tiny bit longer, milliseconds, to build up the pressure to get the volume. So when we're not generating that airstream, we may be working too hard here. So if you're pushing here rather than, hey, I'm using all my air here versus, hey, I'm not taking that air I need to get it. So we may do some little tweaks like with that.
I have a speech, a voice therapy, and she does a lot of breathing.
She did a lot of breathing.
A lot of breathing.
Yeah. Breath is important. I always say it's not, when we speak, we don't need a giant breath. It should be a comfortable breath. Thinking about taking a big breath makes it really hard to coordinate your voice sometimes, but breath is very important. It's the first step for voice, certainly. And go ahead. Did you have another one?
No, I was just saying she does a lot of that, and she does speaking like this, speaking low, learn how to
She
do all
used
that.
to train singers and basically entertainment people itself, and she does this on the side too.
Oh,
It's kind
wow.
of interesting.
Okay.
Yeah.
That's great. Did you have a question? Okay.
What is the injection called? What is the formal word for that?
The procedure,
Yeah, the procedure.
the procedure is called medialization injection, or a VCI, vocal cord injection. There is sometimes we've seen a vocal cord paralysis in a Parkinson's patient too, and there's a more permanent fix for one-sided that is paralyzed. And we see that a lot. You can get it from just a viral illness. They come up idiopathically, and they can do a more permanent fix for that, where they actually go through here, this tiny little incision, and they put a shim in against the thyroid cartilage to move the vocal cord over, and that's called a thyroplasty. So that's
Does your posture, that's your voice?
just say it again.
Posture. Can't sit up straight, so.
Does it affect your voice?
Yeah, does the posture affect your voice on how?
Posture?
Yes.
That's one of my slides coming
Okay.
up. I'm glad you said that. That's a great question, and I'm gonna bring it up now because absolutely. Our head weighs 10 to 12 pounds. When we're tilted even 45 degrees forward, that's like 60 pounds of pressure here. And it also restricts that stream, that air stream for opening those vocal cords for voice. So, and think about where all of us are these days.
Yeah, that's what we-
Our iPhone's right here. Pick that phone up. I'm fussing at people all the time. We get what's now called, they're calling this little, people that are here and are getting these bumps in their back, or it's called a tech neck from being here all the time. So, yes, thanks for asking that.
I don't know if it's that technical, but that hurts a lot.
It's work, isn't it? I mean, we really have to think about that posture. Ideal is like ears over the shoulders, and that's a tricky position, but be mindful with phone use, because we're all coming here, even little kids now, you know, I see high school kids that are completely forward based, and so optimal voice is gonna require that posture. And it does help us project. Now, if you're still, I'm gonna just show you a couple other options for volume. Since that tends to be the primary complaint, and one is just a voice amplifier. I have teachers who use this come back and say, I feel like I have a life at the end of the day. Voice, even in people without Parkinson's, it takes energy and effort to speak all day, every day. These are, when I started ordering these or thinking about them for my patients that needed volume, they were about $300. Now you can get them for like 50 or 60 on Amazon. They're little, they, you know, have the little mouthpiece here, and then the individual little box that you can wear either this around you can put a little lanyard on and wear it around your neck. If you get it too close, it'll squeal, so you'll have to be a little bit further away, or you can buckle it to your belt. They're great. And then has anybody heard of the Speech Vibe? This was designed for Parkinson's. It's an app.
We've seen it demonstrated.
Hey, did you like it? Did you all?
It's interesting. It can be annoying.
My words exactly. But it's got, you know, and I think sometimes we have to think about where we are and what we need. So this was designed for Parkinson's, and as I understand, I don't know the actual cost. When you download the app, you can do a free trial, but it has a little earpiece that comes with it, and what it does is puts background noise in the earpiece, and that background noise makes you speak louder. So, you know, just like if you think about what we all do around in a noisy restaurant, we pick it up a bit. So this buzz is in your ear, making you get louder. For some people that work, you know, if you're going to an outdoor wedding or a restaurant with a big group and you know it's going to be loud, sometimes you may need a little feedback. You can adjust that intensity a little, but something to think about if you're still struggling.
Or something else that I think maybe even a low-tech version, and maybe I can just invent just a different packaging to put them in and then market it to people, but you can just probably put in just earplugs, regular earplugs.
You know, I love those. In fact, I have a lot of patients that are in noisy places, like my bartenders who come in and have voice trouble from talking loud all the time. I'll have them to wear one. That way because most of what we do in a loud environment is we're trying to hear ourselves. You know, so cover one ear and say 1, 2, 3. 1, 2, 3, and you'll see the difference. Yeah, so I think one of those little earplugs can be good many times in that if you hear yourself and that gives you that internal feedback here, we're less likely to overuse our voice or shout too much for too long. Has anybody used one of these, the EMST? Yeah. Anybody else there? This one is an expiratory muscle strength trainer. It has some great benefits and additionally some long-term benefits in sort of driving that voice. It's on, we speak as we exhale, so it's looking at exhalation. It also has some long-term effects that have been shown to establish and maintain a more efficient cough and swallow. They're little devices, you can get them online. You're able to reset the volume so that your resistance changes, or reset a resistance level. So the effort load you need changes. But they have some great benefit for some people. Have you liked it, Jim?
Yeah, I don't use it very often, but I've got one.
Okay.
That sums up my life.
There really have been some studies that are showing great outcomes for longer, keeping a safe swallow longer. Any questions on that part? I'm gonna go into some, actually I wanted to do a little bit about swallowing and then just talk a little bit more about some good do's and don'ts, and I don't wanna run over time, so if I'm getting close, somebody let me know.
You're fine.
Okay. Swallowing, as we talked about, I'm gonna show you some examples of the muscle movement in swallowing, because we know that as Parkinson's is a movement disorder, that swallowing can be affected, and it's certainly an area that is serious. We need to be able to consume calories, to eat, to maintain it, and it's also part of our social life, eating. So the slowness of eating is usually one of the first complaints, that it's taken me longer to chew. It can be to the point that you want to avoid certain foods or going out. Poor lip closure can be another detriment that can cause some drooling of liquids in some people. Weight loss is always a sign. I want you to just think about these and certainly bring it to your physician's attention if you're noticing these. It can, especially if there's any coughing or choking as you eat or drink, that your physician needs to know that. There are tests that can be done to see why that's happening. As I said, it's serious. It can lead to malnutrition. Dehydration is a big one too. That can cause lots of additional problems. And then aspiration, which can lead to pneumonia. So it's very important to stay on top of what you notice and in terms of your eating. It's a day-to-day chore. We're all doing it, so sometimes we're not as mindful. But if you start noticing, gosh, I've been coughing on liquids the last month, certainly bring that up so that they can direct you for the testing that's necessary. Anytime you're noticing the coughing or choking, either with a meal or after a meal, make note of that. Weight loss, if that's occurring, that they usually will weigh you at the doctor, so they notice that. But it's certainly bringing this up. Even if you're feeling food stick in your throat, there are 3 phases of the swallow: the oral phase, the pharyngeal phase, which the oral phase is getting the food back, chewing. Once it hits the back wall, that's the pharyngeal phase, and that's where the airway's protected by the vocal cord closure. So if vocal cords are bowed, we don't get the closure we need for complete airway protection, which can lead to some of that coughing issues.
Is chewing gum have any effect on anything? Chewing gum?
Say that again, I'm sorry.
Chewing gum, does that have any effect?
Good or bad, I don't know. I mean, you're using muscles as you do it. For some people, they like it because it gives you hydration, but if you were more likely to aspirate liquids, that may be a little tricky to be producing more saliva. So one of the things with swallowing is it's so case specific that it's hard to say, do this. Because if your area was strictly like muscle strengthening, cheek being weak, that would be a good thing. But if it were at the laryngeal level, where you felt like you're not protecting the airway, then it may be more difficult. So swallow study is what they order. It's a very easy test. Anybody had one? Okay. All right, so you go to x-ray, and this is what it looks like. You'll take, they put a little barium in liquid and thicker liquids, and as you can see, that closure looks like it's all going just in one lump and not much really happening, but the base of the tongue has to contract with the back wall. This little, the epiglottis is a little flap there that has to flip and protect the airway. The vocal cords close, the hyoid bone elevates. It's a choreography of amazing movement here to do airway protection. We use many muscles to complete that. So general rules, as I said, this is always pertinent to you and what is seen on the swallow study, but usually a slower rate of intake, allowing yourself time to swallow. When people say it's taken longer to eat, that's probably a good thing, and muscle movement is, we would keep that up. If need be, and solids are the most difficult, certainly fork mashing foods, if needed, can help you get the nutrition you need without exhausting yourself. I tell people too that if you notice vocal fatigue to be a big problem, pattern yourself out. Get more of that protein early in the day. Eat. Then I think there's always that saying of eat breakfast like a king, lunch like a queen, and dinner like a pauper or something like that. Isn't that? Yeah. So if you're someone who does because of Parkinson's, and even there are many other neuromotor issues that can cause that vocal fatigue, try to get your calories and nutrition packed in the early part of the day when you may find that you have more energy. That slower rate of intake is going to be good. Effortful swallow. It's one of those where you think about swallow like it's something you don't like. Or a little bit of peanut butter. Put a little more power in it, just like you do in your LSVT loud and LSVT big, just volume and more effort for the walk. You need it for swallow sometimes too. Many times upon doing a swallow study, there are choices that we make in terms of how thick the liquids need to be, or things like that, or should you swallow 2 times? Sometimes a second dry swallow can help. There are lots of things that would be determined based on a swallow study. So don't hesitate to ask for that. It's an easy procedure. If anybody's noticing problems or issues, please let your physician know.
I got a question about drinking. I can drink through a straw, and I've heard some controversy about that.
Do you like to drink through a straw?
Yeah.
Yeah. So the straws there are 2 things that can happen. One is that it sends it back there too fast for our body to protect and start the closure. When people like to drink through a straw, what I typically tend to have them do is tilt their chin forward a bit, so it's a more deliberate, you get the liquid in your mouth and then swallow, versus when you're up and just sequentially swallowing. If our muscles aren't as timely as they used to be, we may not be able to protect our airway as fast. So you saw that coordination of the back of the tongue going back, the hyoid lift and the epiglottis flipping and the cords closing. All that has to happen before. So that's why a lot of times in a swallow study, they'll say avoid straws because it's too fast.
Yeah, because if I drink without a straw, I have lots of problems.
If you're tucking your chin and you're keeping it here and then initiating an effortful swallow, it can usually be effective. I like to, now that we're at the Voice Center, we don't have the radiology department, so I don't get to do those as often, but I used to actually have people do that with the straw, really try that to see, because for some people, if you like the straw, it takes, go ahead.
Yeah, I was just wondering, so with the bowing, when you start having the bowing of the larynx, do you just constantly have a little bit of food or liquid just constantly going in the airway? Because it's not closing all the way?
It can. It can be little trickle amounts, some people even just saliva can come back.
Oh.
It's not, now, remember there's lots of ways to airway protect, because so if the cords aren't coming together, the epiglottis is over and it will often protect.
Okay.
If that movement's slow though, it may let a little leak down before.
Okay.
And I over time tended to be a little less conservative. If I saw just penetration, I know some people that do a swallow study and see it are like, no, but hydration's a great thing. We all need it. We have to have it. So I feel like finding the safest way to get food in, and that's it. I will say, when we see a patient at the Voice Center, because our laryngologist is associated with us, that's one of the reasons to do an injection sooner rather than later, if aspiration is suspected or a problem, because we certainly want to avoid any pneumonias anytime. Has anybody ever been placed on thick liquids? Yippee, good, because most people don't like those. So we talked about the fatigue.
Like ice cream and stuff like that?
Milkshakes, yeah, milkshakes are good, but most people don't like thickening coffee and things like that. You can buy a product with, it's a common occurrence after strokes and things like that, where muscles are weak. Usually that's a temporary. But I know we talked about this being more speech and voice, but I did want to highlight swallowing, because it does become a risky area, and that, I think thinking about those. So what about communication? I know those of you that have been in therapy have probably thought about this. One of my big ones is thinking about, just as we talked about monitoring when you eat and getting your energy in the early days, even everybody that has a voice issue, I like to say that think about our voice like a budget, something that we have to balance. So if you have, you know that tonight's gonna be a big event with family and friends, and there's gonna be a lot of people around during the holiday time, you may pace yourself and let your you do less of the effort and energy in the beginning of the day. Sometimes that may be a time to think about something like an amplifier. Even those that don't have issues with volume as much, when they have big demands, like speaking at the state fair for days on end. Sometimes a little amplifier may be a good thing then. Just looking at where you feel energy load and where you feel like you can get by, and balance it out for you. Some other things that can help. I always say communication is two ways. And we know that the person with Parkinson's is doing more than their effort to get it through. So really trying to maintain eye contact when you can. That's a big one, I think. And part of that vocal budget, those vocal naps, give yourself a few minutes rest, especially if you start to feel strain, you notice that it's more effort to talk. You don't need a long rest, but just a little break in there. Give yourself a 5 minutes sometimes to just capture your breath and go through it. Replenish your breath's very important. You mentioned that breathing was a big part of that. Releasing your breath as you speak. As I said, it doesn't have to be a big breath, just a comfortable breath. I call them sometimes as we speak, you're not aware that I'm taking a breath, but lots of little catch breaths are happening, little tiny breaths between phrases and pauses, and that's important to keep that voice. Also, if you can keep things in shorter, concise phrases, that I don't want to alter what you're saying, but think about giving the information in little smaller units, especially if you're noticing that articulation or the clarity of your speech tends to be more difficult. And as I said earlier, speak louder than you think is necessary. And the two big ones we can all do is good hydration. Very important, and I had the benefit of you asking about posture earlier, so I want to talk about these two because we can all do this. It's great for your voice. I even in college thought, what the heck does hydration have to do with voice? Why does it matter? It doesn't hit the vocal cords. But we know now at the cellular level, when vocal folds are well hydrated, they're much more supple. So it's very important to up that water intake. If you tend to be a big caffeine person, just try to back up your caffeine with water. And my friend here, yes?
What about like diuretics? Do they affect your hydration to the vocal cords?
Just what?
Diuretics.
Oh, diuretics, thank you. Yes, that's a, they can. Yes, that's a great,
You know, my dentist says that, you know, people my age are seeing more cavities because of people having dry mouth. And
that's, yes, it certainly does. And I think a lot of medications cause drying, not just the diuretics. So look at your medicines. The more hydration, the better. I typically have water with me all the time, and I got a little nervous when I came in today and realized my water bottle's in the car. You do, it's very, it's comforting to me to know that, but really, if you look at a lot of the diuretics but some of the antihistamines that we use this time of year especially, they all have drying effects that can make a difference. So be mindful of that, and you know, being aware that excess, and a lot of times I know you don't want to, you don't want to be in the bathroom all the time, so everybody's avoiding the water, but it is a great thing for our overall vocal health. And I had to bring up posture one more time because it's something we can all think about and try to make changes. So hydration and posture, and we can't always avoid medicine that have that drying effect, but that's a great, I'm glad you brought that up. Questions? Yes, sir.
Is there a connection between vocal fatigue and the ability to find your words to complete sentences? Is there any connection there?
That's a good question. No, usually the vocal fatigue to me is what's happening with that voice, but that if you're working harder to think of words, is that what you're referring to? Just that?
Yeah.
Usually they're two different things, but certainly both have a huge impact on that communication and the energy load, the cognitive load of speaking. You know, most of the time we're talking, not thinking about it, but when you're having to struggle for that word, pausing is happening, and during that pause, sometimes we can hardly, we can hold our breath, or we can just let that air go, and it's certainly easier to let yourself breathe through those episodes, which is, it's a tricky one. That's a good question.
All right, so thank you.